I mentioned this refugee kind of mentality before where people are running away from something. I think we're in a generation now where a lot of us in the DPC space, especially those of us who are younger, are trying to build something so that we have the freedom to do something, right? Freedom to take care of our patients, freedom to help them navigate and really do a good job moving forward.
Welcome to the Physicians and Properties Podcast, the show where we teach you how investing in real estate can give you the freedom to practice medicine and live life how you want.
Doctor! Doctor! Doctor!
Doctor! Doctor!
Now, here's your host, Dr. Alex Schloe.
Hello, everyone. Welcome to another episode of the Physicians and Properties Podcast. I am so excited to have a med school friend on the podcast today, Dr. Kenneth Qiu. It is awesome to reconnect. He is a family physician, a leader in the direct primary care movement, and someone who believes that primary care exists best outside of insurance and hospital systems. After he finished residency, he went straight into building his own direct primary care practice, which is a bold move that gave him the freedom to practice medicine the way that it was meant to be practiced, with time, relationships, and a focus on patient care over paperwork. Beyond his practice, Dr. Qiu advises healthcare leaders in policy, finance, and tech, and he is helping to shape the future of healthcare through the lens of primary care. I'm excited to dive more into his journey and explore what direct primary care really means for doctors, patients, and the system as a whole. Dr. Qiu, good to have you on the podcast, man. How are things going?
It's good. It's good to see you again and great to catch up.
Yeah. Absolutely, man. It's been a while. It's really cool. Really cool to have folks on the podcast that graduated from BCU, MCV, and it's awesome just to see what folks are doing. And you are doing big things, and so really excited to reconnect with you here. Let's just jump straight into it. Right after residency, you launched your direct primary care practice. What was that like for you? What led you to take that leap instead of following more the traditional private practice route?
Yeah. So I learned about direct primary care as a fourth year med student. It was one of the decisions that led me to choose family medicine. So by the time I had finished residency, I had already talked to at least 100 DPCs across the country, visited dozens, and, I was just sold. Part of how I got into direct primary care was even in med school, I ran several student organizations and did some work with the medical society. And so I was just trying to educate myself about the healthcare system even then while learning medicine. And everywhere I turned, it seemed to be like, this is bad, this is broken, there's no hope, we don't know what to do. And then fourth year med school, I made it to the DPC summit that happened to be nearby in Washington, D.C. that year. And the attitude was so different. It was, this is how we're fixing it. This is what we're doing. This is how you can solve this problem, that problem. And I think I just got caught up in that energy. And I started reaching out to people, learning more about it. And, it really, even at that time, 2017 felt like something big was about to happen. And so when I started my practice in July of 21, it was kind of natural. I couldn't think of doing anything else. And I guess, it is hard, right? Because you come out with debt, you got to make your own income, you start a business and you got to spend. And so I worked full time at urgent care for a while ramping up my patients. But it's been rewarding. The movement's growing, the model's growing, and a lot of people love it. And, we're 4 doctors now across 2 clinics. So I've been having a great time and have no regrets doing it.
That is awesome. Yeah, I remember you and some of our friends going to Capitol Hill when we were in med school and chatting, with the state governments there and, talking about policy and those sorts of things. Was that when you kind of first got exposed to direct primary care, or was that when you really realized, man, healthcare is broken and there's got to be another way, or maybe a bit of both?
Yeah, a little bit of both. So it was nice because we went to school right across the street from the Capitol. So it's pretty easy to just go over there for the white coat days and all of that. I think policy is just a piece of the puzzle, right? Healthcare in general is kind of a blind man and elephant problem, right? Everybody is in their little silos and everybody is like touching their thing. And one person says it's a trunk, another person says it's a rope, so on and so forth. And that's why even from an early stage, I was doing the white coats on call, but I was also engaging like the CEO of ECU, a lot of the business people, policy clinicians, just trying to get as many stakeholders as possible to really see the picture. And again, it was a landscape of stuff doesn't work, it's broken forever. And then DPC was, I think that was my first taste of entrepreneurship, really, because all these people, what made them different was they're entrepreneurs. And I'm sure you know, as you're one, entrepreneurs are people who are chronic problem solvers, right? We like to see opportunity in what's broken rather than just kind of sit and wallow in it. And so I think that's what really drew me into the community.
Yeah, absolutely. I feel you there. I am definitely a problem solver, but also a visionary and have way too many ideas. And I think that's part of entrepreneurship as well. And then figuring out, hey, which of these ideas can I implement? Which of these ideas are actually going to make a difference and change the way things are done? And I think direct primary care is definitely a path that does that and is certainly a step in the right direction of how primary care should be and really how our healthcare system as a whole should be. Let's talk a little bit more about those early days. So what challenges did you face initially and what kept you moving forward in terms of your practice? Definitely difficult, especially at the time that you started in 2021. I feel like the kind of wave of direct primary care was just getting started around that time frame.
Yeah, I think that there was definitely a lot of activity around 2013 to 2017. And you're right, we were still early. I think we were probably the third DPC practice in the Richmond area at the time. And there's, like 7 or 8 of them now. It's pretty wild how they've all sprouted everywhere. But I think, like I mentioned before, you come out with med school debt, you have to spend money on the business. And then so I actually started with a friend of mine from Residency, Dr. Mariana Keener, and she's been awesome. In general, like when people are starting DPCs, I wouldn't say recommended, but the ones where you have somebody else start with you, whether it's a friend, a spouse, whether it's another physician or an office manager, it just makes things so much easier and better when you can share the load, because it's hard when you're starting out. And so we started as new doctors with a new model in a new town, didn't know anybody. And so the ramp up was slow. You hear in the community how long it takes to get to 100. On average, it takes about a year, give or take. If you come from somewhere nearby in the system, if you have a lot of recognition, it's fast. But if you're new, it's a slow ramp. And it was a slow ramp for us, especially since we were trying to do this thing and both of us were working full-time at urgent care. So I think patient acquisition starting out was the hardest thing, balancing finances and really just working 2 full-time jobs to get the thing up and running.
Yeah, absolutely. That would be incredibly difficult. What were some things that you guys figured out from maybe a marketing perspective or the patient acquisition perspective that was really helpful for you to grow?
I think from marketing, the key is word of mouth. And this was something I didn't know was like an act. I always thought it was something passive that just happened, right? But I was talking to a business person and they talked about word of mouth strategy. And so all that means is just making it easy for people to refer to you. There's the more passive, easy stuff, which is like create a great experience. Early days, you really bend over backwards for your first few members and go above and beyond. We haven't really strayed too much from that in terms of exceptionalism and really being there for patients when they need it. But you really kind of do as much as you can. And then actively, some things to be more mindful of are like when patients would finish their first visit, we'd send them out with brochures, right? Just say, hey, if you like this, we're new here, tell 3 people you care about us. And that helped. And then since then, we have all sorts of just random swag that we give out just to be top of mind for people. The online stuff didn't really work so much for us. We were in social media. Neither of us were very good at socials. Our socials not great. We did some Google, which led to just wrong phone numbers and nothing. Facebook ads recently have been helpful, but we're just trying that. So our growth is pretty much just, some local community networking that I did early on. And then once you hit that 100 patient mark, it's just snowballs because everybody starts talking about you.
Yeah, I feel like direct primary care, you can provide such an exceptional experience that people will, when they first hear about direct primary care, they're like, this can't be real, right? And then they go and experience and they're like, wow, this is amazing. And then they want to tell folks about it. I mean, the practice I'm at now, Alpenglow Direct Primary Care, that's the same thing for them. Like it's just largely been word of mouth because it's like, hey, this is such a different model and such a refreshing take to medicine. And that's how they've been growing. And so it's just really, really cool to see that. And it's wild to me how many people have no idea what direct primary care is. And, can't even fathom that it's a thing. And, I'm talking to people all the time about it and they're like, what? That's real? That's an option? I don't understand. What are some things that you have kind of honed or learned in terms of describing what direct primary care is and the value that provides? Is there, I guess, what's your kind of elevator pitch for direct primary care?
Yeah, I think there's a couple usual boilerplate talking points we use where it's like, oh, you don't use your car insurance for oil and oil changes or filling up gas. Otherwise, your oil change might be $3,000 and out of network, right? There's the idea of, more so actually Costco than Netflix because, Costco, you come in and then you have all this stuff that's brought to you at the best prices, right? Because we're navigating meds, we're navigating labs, imaging, all this stuff for our patients. So it's a little bit of Netflix, a little bit of Costco. And recently I've been trying to teach myself how to be better about selling the feeling rather than the features, right? That's pretty basic advertising 101. Because when I started out, I would go to people, I'm like, oh yeah, we do this thing. It's a monthly subscription. You get unlimited visits. They're 30 minutes long. You can text, blah, 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 blah. We do labs. And then, you watch their eyes glaze over and you don't know what to do about it. So now I'm more so focused on just saying, look, the system's broken. We're trying to take really good care of you. Insurance makes things pretty complicated for both you and us. And here we just don't accept insurance. It's low monthly rate just to cover everything. No copays, no office visit fees, nothing. We want to keep things predictable. We want you to be able to access us when you need it. And our end goal is just to have a direct relationship with you and take really good care of you. And then if they want any more details, they can ask.
Yeah, that's beautiful. Yeah, selling that story, selling that experience is something that I'm definitely learning because you're right. Like they get hit with all those cool features and things of direct primary care, and it's almost overwhelming at how awesome it is that it doesn't even seem real. And, and then there's always that, well, I have insurance. And then people don't understand that, like, hey, you may have a high deductible insurance plan. Direct primary care is still an incredible opportunity, still a great value for you, regardless of insurance. I mean, I figured that out just navigating insurance as I transitioned out of the Air Force for my family. And I'm like, this is crazy how much it would cost for this really terrible high deductible health plan where there's no access to care when I could, do a different model, do direct primary care with a health share or something else along those lines. So it's so interesting how much confusion there is around insurance and just honestly how terrible it is and how terrible of a deal it is.
Yeah, I think the other thing I wanted to mention is concierge because a lot of people, they hear like, oh, really good service, all this crazy access. They're like, oh, your concierge care. This is where there's some people in the community who use concierge in their marketing, but it's a hill I choose to die on. The way I define concierge is membership plus insurance. So historically, the vast majority of them will double dip. If you see a higher monthly membership that doesn't take insurance, I tend to call that like executive DPC because technically it's still insurance free. And so concierge, they'll sell you bells and whistles and all this stuff to justify their fee. Whereas we just care a lot about just relationships and navigating the health system for our patients. And a lot of that includes education on, different types of insurance or alternative plans, what a high deductible means, HSA. I'll kind of jump the gun a little bit, OB3, the One Big Beautiful Bill Act. There is a provision in there for DPC practices where HSAs are officially compatible with DPC. So you can have a high deductible plan, fund an HSA, and then use those HSAs dollars for your DPC memberships if you want, which is huge, right? That's almost the equivalent of like 2.5 free months if you do that, depending on your tax bracket.
Yeah, that's amazing that's the case. And I don't know why it took so long for HSAs to be able to be used, since you can use them for all kinds of other things like wearable, electronic health devices and so forth as well. So yeah, super excited about that. Dr. Qiu, what are some misconceptions that doctors may have about DPC, specifically like think back to your time in residency? What are some things that might keep a family med resident from considering starting or joining a DPC practice?
I wouldn't say there. So, okay, there's two categories. I think as far as misconceptions go, a lot of it comes from maybe older doctors or academics who see this as something where doctors who just want more money leave the system and do it. Poor people can't access it. You're only serving the healthy, young, rich people. And the other thing is worsening the doctor shortage, right? Because we're going from panels of 2,500 down to, like 400, 600. Those are all very complicated topics that I could go into depth, but we're not going to do that today. In short, DPC takes care of a lot of underserved populations who aren't getting good care or any care at all from the system, right? The people who use the ER as the front door now have primary care who are controlling things. These small businesses who can't afford anything else, helping those out. And then as far as the shortage, that's a little more complicated topic just because there are a lot of different factors, people who would be quitting the workforce, who are staying in, more students who are now interested in the primary care field. And then as the model evolves, how can we maybe leverage more of a care team to take care of more people over time? And none of that has been solved yet, so it's more complicated. As far as people joining or starting one, I wouldn't say it's misconception so much as the financial realities, right? Debt is the main thing, and then business know-how. So whenever people are hesitant, it is one or the other or both. Yeah, the golden handcuffs are very real. You got your sign-on bonus, you got your stay with us bonus. And then, of course, the system currently still pays a lot more. And then even if you have saved up a nest egg, it's like, okay, I've never started a business. How do I file an LLC? How do I make a website? What do I do for marketing? And then all these things that we're not trained or taught to do, how do you do that? So I actually just did a big survey. The peak age for having a DPC right now is age 40. When people have saved enough, they're frustrated, and then they get going. And then from the business standpoint, the Direct Primary Care Alliance, other organizations, man, there's so much information out there right now between the conferences, podcasts, workshops, whatever, to help you start. It's never been easier to start a practice as it is today.
Yeah, I feel like too, the DPC community is so collaborative and understanding of like, hey, there's such a massive need and we need more and more of these DPC practices. And there's so much demand and not nearly enough supply that like that competition's not really there. Like everyone I've ever talked to in the DPC space is all about, hey, how can I help you grow your business, or what problems do you have and how can we work through this together? And it's just a really collaborative environment and community, which is awesome.
Yeah, that's right. It's a little bit of refugee camp energy, right? Because everyone has left the system, that they're all burnt out and they're like, gosh, I remember when I was there. Let me help you. Come into this tent. We'll get you fed, clothed, and help you start up.
That's a great analogy. I love that. Well, you mentioned that starting a practice, that's very entrepreneurial. How did you approach building the business side of DPC? How did you learn how to start a practice? How did you learn to grow your practice? Anything in particular that stands out?
Yeah, just talking to a lot of people. Like you just mentioned, the DPC community is very friendly. We have a lot of online forums. I reached out to people in my backyard. There was a couple that was in the class above me in residency. They started the year before me because they graduated a year early. So when I was launching, I really leaned on their 1 year of experience to see. And then again, nationally, just knowing a lot of DPC practices all over the country, asking them how to do things, and never feeling like I was too good to ask a very basic, dumb question. I like asking dumb questions. And yeah, just the wisdom of the masses is what really helped.
Yeah, absolutely. I love being the dumbest person in the room, from med school to now, still am. So it's good. That's awesome. So I know you also kind of advise in the policy, finance, tech side of medicine. What are some trends that you're seeing in those spaces, and kind of how do you see direct primary care fitting into the broader healthcare landscape over the next 5 to 10 years?
Wow, big question.
I should have prepped you on that one.
Yeah. So there's a couple of different things happening. So as far as like independent DPCs, those are popping up so fast, like unbelievably quick. When I learned about DPC 2017 in the Richmond area, there was one practice. Today, there's like, 7, 8 maybe. And all the ones that are established are still going. Several of us are adding new docs, adding new locations. Like it's picking up from an individual standpoint. And I think nationally that's been growing as well. So the individual practices are doing well, continuing to grow. Then you kind of get into I call them like the bigger networks or multi-location groups. There's still, I could probably count them on, both hands how many there are, but they got big because when you go direct, there's 3 ways that healthcare is financed: by the individual, by businesses, and by government. Businesses cover 50% of Americans, government about a third, and then 20% individual. And so you start with small businesses who, they'll start with a CEO. They're like, this is really cool. Can I sign on my 5 employees? A lot of manufacturing, construction, those types. And then you're like, yeah. And then you start finding more, small business CEOs, and they join and they talk. And then all of a sudden now you're in the kind of 50 to 100 employee range. And that creates a whole separate series of challenges and opportunities. And what these larger DPC groups have figured out is how to work with these large employers when it comes to care navigation, when it comes to some data collection, really learning their kind of cycle, HR, understanding level funded, self-funded plans. And that's also growing really fast as employers are struggling. The premiums keep going up. In this country, once you become successful enough as a business, you get to become an insurance company. That is the unfortunate reality. And as their costs are going up and the brokers are telling them, well, there's nothing we can do, 20% increase premiums, whatever, they're learning to direct contract with direct primary care practices. And in doing so, not only are their premiums not going up, they end up saving money year over year. And so that's creating some serious tailwinds for the movement. And because the direct primary care groups aren't big enough, they'll kind of subcontract with the independents. And so the small independent practices, the one or two clinics, also benefit from the interest in employers because now they're getting employees funneled to them through these kind of larger groups. And yeah, there's a lot of interest in the business space. And then government, this administration, through whatever they're doing, they do have DPC on their minds. RFK talked about it in his testimony. There's interest. And I think we are just trying to figure out exactly how this is going to play out. The HSA win was a big one for us. That's going to empower a lot more people to access us, a lot more employers to build out truly high deductible insurance plans and sponsor DPC memberships. So we make insurance catastrophic again while providing good care. And I think when it comes to Medicaid, Medicare, there's still a lot more discussion to be had and a lot more thoughtful people need to come together to figure out how to make it work properly.
Man, that was an amazing answer. Yeah, I completely agree. I was just doing some reading, and I think it was like 53% of folks that are in direct primary care, employer-based, 53% less ER visits. Absenteeism drops dramatically, right? Because access is so much better. Instead of going and waiting to see the doctor, for 2 to 3 hours, it's a lot quicker, or it's virtual, and folks are returning to work faster. So there's like so many benefits for the employer, not to mention the cost savings, which I think in Colorado was like 24 to 30% cost savings for the employer to do to sponsor DPC and do either high deductible health plan or a health share. So just really, really interesting. And it's really cool to see how this is starting to play out. And it really exciting, obviously, for both of us in the DPC space to see how that lands. I think it's going to be awesome. I think the next 5 to 10 years are going to be crazy to look back on and see. I think something really has to change in the healthcare system. And we could talk for many hours about that in terms of what the healthcare system in America looks like in the future if things don't change. But I think direct primary care is a breath of fresh air in the right direction. So really excited about that.
Yeah, that's right. I think sometimes about the Freakonomics, I think it's like chapter 1 where they say everybody's walking to the subway one way, and then there's like construction and people find different ways. And when the construction goes away, people find that, they found faster routes. I think DPC is a little bit of a shock to the system as well, because it's just like, we're just not going to do this anymore. People are like, what do you mean you're not going to do insurance? That's just like how things are done. We're like, nah. And then people start finding new ways, and we're building an ecosystem, right? I mentioned this refugee kind of mentality before, where people were running away from something. I think we're in a generation now where a lot of us in the DPC space, especially those of us who are younger, are trying to build something so that we have the freedom to do something, right? Freedom to take care of our patients, freedom to help them navigate and really do a good job moving forward. And so we're looking to build now in this kind of new land and create a new standard of care.
Yeah, completely agree. So multiple locations now for you. When you went from 1 to 2 locations, was there like a specific metric you were trying to hit? If you're like, hey, once we hit this many patients, we're going to open another location? Or was it provider based? Like, hey, you had a provider in mind who was going to start that new location for you? What did that look like in terms of deciding to start a new location?
Yeah, so my initial practice, it's a suburb of Richmond called Midlothian, which is south of the river. And then one of my buddies wanted to join me. And this was this past October. He was like, let me come work for you. I was like, I don't have the bandwidth right now. He's like, doesn't matter. I'm doing it. And he worked at a fee for service north of the river, kind of in the West End. And so, you know this because you went to school in Richmond, but people north of the river don't go south of the river. That's just how it goes. And also the space I had in Midlothian really could support 2, not really 3 full people. So I was like, all right, there's opportunity here. I know he's going to do well. So found a space up north of the river, plopped him right in. And sure enough, tons of people followed him. I mentioned it took some time for us to build up, being new doctors, new model, new place. But he only worked there a year. He brought in like 300 some he hit 300 within 6 months. The bottleneck was just how fast he could onboard people. It got to a point where I saw him approaching burnout. I was like, all right, we got to pull back. We got to chill out a little bit. This has to be sustainable for the long run. But he did well. And then just by sheer luck, another one of my friends from Residency reached out just a couple months later and was like, hey, well, he had listened to another podcast I was on it like 3 years ago. And I was like, why are you listening to this? He's like, I hate my job. I hate everything. I wake up and I get a knot in my stomach just dreading the day. And he's like, I don't know how to start a business. I don't know how any of this works. I was like, you want to just come work for me? He's like, you let me do that? It's like, yeah, come on in. So I had a 2-doctor space essentially in the West End, and we were just going to kind of lose money on the back half of it. Not lose money, but, just pay extra. And we got lucky. He just a couple months in, now he's there and seeing patients and building up. Not nearly as fast as my third guy, but a lot faster than me and Dr. Keener did at the beginning. So we're doing well and growing.
That's awesome, man. What's next for you guys?
Yeah, that's a good question. We'll see. I mean, the things we're doing, we're actually a little behind, but I'm glad we're finally doing it. So we have dispensing now. So we just launched dispensing in our Western location and should be up and running by the end of the month in our Midlothian location. I mean, we have a partnership with a gym where you actually get discounts on both the gym membership and our membership if you join both, just to encourage people to exercise, walk the talk. And I pay for everybody in our clinic to join that gym. So we're also living out what we preach. And the other thing, I guess, that's on the horizon is trying to get some third years. Now that we have enough patients, I'd like to have some med students because I want to teach them how to practice good primary care. I don't want their experience to be just running from room to room and with a burnt out doc talking about codes, right? I want them to experience what it's like to message patients, learn async virtual care. You got to learn how to do that as a doctor now, right? Like not everything's going to be in-person visits. Learn how to do some population health when you have the time to just kind of look through numbers. Now, I do want to have enough experiences for them in person because, as you know, third year, it's important to just see the pathology. And I actually want to build out basically a really super discounted membership where we have like some sort of application so people can come in and work with the med students. But yeah, that's one thing that I've been thinking a lot about. I would like to figure out how to integrate like physical therapy, mental health, but those are all kind of dreams right now that I'm thinking about. Yeah. And then I mentioned the employer space. We continually talk to employers and try to, just educate employers more about what their options are in healthcare and how we can take care of their employees better. So those are just off the top of my head, some of the things that I've been thinking about.
Yeah, you're going to be busy. a lot of awesome things, man. Yeah, that is cool. Kenneth, I guess if you had to kind of wrap up how direct primary care has allowed you to be the family physician that you want to be, how would you answer that?
So I would say it's allowed me to, we all have only so much time in a day and we can only think about so many things. And as business people, we are trying to optimize for things, right? And I would say direct primary care, instead of running a business where I'm constantly thinking about collections, about which codes, code maximization, throughput, those things, metrics that don't matter, like I just kind of rattled off, the things that I'm thinking about, how do I educate the future? How do patients have a much better seamless experience? How can I better help them navigate across the health system when they actually have to go to specialists? Is there a way that I can do better follow-up? How do we schedule messages to be more proactive with patients? What are ways that we can bring more value, like dispensing, where our meds are cheaper than Mark Cuban's Cost Plus, cheaper than GoodRx, and they get to leave from the visit with bag in hand. So getting to focus on the right things has been super rewarding. And when patients run into problems that are kind of more systemic, I get to think about like, okay, why do we do this way? How can our practice kind of navigate around it or do it better? So I think just getting to focus on the right things has been really rewarding.
That's awesome. Yeah, I was listening to a podcast called Founders, which is about different entrepreneurs and CEOs. It's really, really good.
Great one.
And I was thinking about, as you were mentioning that, the episode that was recently done on Elon Musk. And if you would just walk around and be like, delete, 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 anything that could be deleted was deleted. And I think direct primary care does a good job at that. And there's still definitely a ways to go, but we delete a lot of those things that are completely unnecessary in healthcare and streamline that experience and provide way better care. So, man, I love it. That is awesome. Well, Kenneth, where can folks reach out to you if they want to know more, if they want to follow along on your journey? Is there some place they could reach out and connect with you?
Yeah, I mostly just post on LinkedIn now. I call it millennial Facebook, right? We all got jobs and we like to post about our jobs. So yeah, pretty active on LinkedIn, and then the DPC conference circuit or usually some of the bigger primary care conferences, I'll be there. So those are probably the two ways that you can find me. Or if you're in Richmond, Virginia, feel free to reach out.
Yeah, that's what I was gonna ask. What's the name of your clinic for folks that are in the Richmond area that are listening to this?
Yeah, so my practice, this name is too clever for its own good. Rule number one of marketing is have to explain your practice name every time. It's called Eudoc. It's spelled EUDOC. The idea is it comes from the Greek prefix eu, right? So state of good well-being, euglycemic, euthyroid, things we use in medicine a lot, and then doc for doctor. So the good doctor, or doing medicine the way it should be done. And then the pronunciation is Eudoc, being you and the doctor with no middleman. So it's got a bunch of layers. It's overly complicated, but there it is. So Eudoc.
I love it, man. That is awesome. Yeah, folks, listen and check out Eudoc there in the Richmond, Virginia area. Dr. Kenneth Qiu, it's been awesome having you on the podcast, man. It's so good to catch up. Hopefully it's not multiple years in between going forward. So we'll have to have you back on the show as things continue to grow and expand. But thanks for taking the time to chat on the podcast tonight.
Yeah, absolutely. Thanks for having me. It's been great to catch up.
Awesome, man. With that, it's been Dr. Kenneth Qiu and Dr. Alex Schloe with another episode of the Physicians and Properties podcast. Signing off. Hey, real quick, if you're still listening to this, I'm assuming you got value from it. So I need your help specifically. My 2-year vision with this podcast is to help 100,000 physicians learn how investing in real estate can give you the freedom to practice medicine and live life how you want. There are 2 main ways that a podcast grows. One is through ratings and reviews, and the other is word of mouth. If you can please leave me a 5-star rating and review on Apple Podcasts and Spotify, as well as send this to 1 to 2 friends that you think would get value from it, we can reach the physicians that we want to reach. Thanks in advance, and talk to you on the next episode. Please note that the information shared on this podcast is for informational purposes only. It should not be considered financial or medical advice. The views expressed on this podcast are those of the host and the guest and do not necessarily reflect the views of the Department of Defense or the United States Air Force.